بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. حياكم الله جميعا. I'm Dr. وجدان الزهراني, neonatal fellow in National Guard Hospital in Riyadh. I will be the moderator today for this session, inshallah. I would like to welcome to you all and thank you for attending. Also, I would like to thank Dr. Adnan for arranging this lecture. Today's lecture will be presented by Dr. Jubara. She will talk about difficult airway management. Dr. Jubara graduated from King Abdulaziz University in Jeddah. Her pediatric residency program started in Saudi Arabia, followed by neonatal perinatal fellowship program in Canada, University of Manitoba. She was director of neonatal fellowship program, National Guard Hospital in Jeddah. She is director of Saudi neonatal resuscitation program. Also, she is board member of Saudi Neonatal Society and board member of Journal of Clinical Neonatology. Currently, Dr. Jubara is a consultant neonatologist, assistant professor of pediatrics, King Saud bin Abdulaziz University of Health Science, King Abdulaziz Medical City, Jeddah. Thank you, Dr. Jubara, for being us today and taking the time to present the important lecture. For audiences, I encourage each and every one of you to actively participate, ask questions, just write it in the chat. Let us take advantage of this incredible opportunity to learn from one of the brightest minds in our field. Dr. Jubara, تفضلي.
Thank you very much, دكتورة وجدان. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. First of all, I would like really to thank all of you for giving me this great opportunity, and it's really a great pleasure and enthusiasm that I will be here today as a speaker and having the opportunity to share insights and perspective in a very important topic in the field of neonatal medicine. And really, I hope to engage your mind and report thoughtful discussion and inspire you throughout this hour and to highlight the important topic, which is management of the difficult airway. And you know, management of emergency neonatal airway can be the most an anxiety-provoking and challenging situation faced by all clinicians who's dealing with neonate or attending delivery room or in hospital where there is no neonatologist. So they are the people who face such challenges. I will start my presentation with a scenario. So you called like as to attend delivery in the middle of the night, like as the usual 1 a.m. A mother with severe polyhydramnios is being taken for an emergency cesarean section due to an abnormal CTG. And antenatally, there was a large cleft palate and on the antenatal ultrasound. So what do you think you will do at this point? Maybe you can write in the chat. Because it's like it needs some discussion, but I may go through that while people are writing on the chat. So in these cases, you need, before going to delivery room, think what you may face with. A baby with cleft lip and palate. Yes, you may be an expert fellow F2 or F1 who's like had some experience delivery room, but it's not the case which happen every day. So this is the baby born, and the baby is not crying, not breathing, and this is the face. As you can see, a baby with severe micrognathia. So what you will do in this case? Okay, so usually you will start, most of you are expert in neonatal resuscitation. So when the baby born, you evaluate the baby. This baby is not breathing. So you start your initial steps. Warming the baby, drawing, stimulation, position, and if there is some secretion, you will suction. So you suction the baby and you did your initial steps, but still the baby is apneic. So as per NRP algorithm, what you need to do, you start passive pressure ventilation and call for help, of course. How to give passive pressure ventilation in these cases? Majority of failure of passive pressure ventilation is due to mask seal problem. Yeah, because he had severe micrognathia, so sometimes you will not have an adequate seal. So how you can ventilate this baby? This is a case I'm pretty sure every neonatologist and staff and pediatrician, they face such case. So this is considered one of the difficult airway. So if you try to intubate, for example, this baby, you have difficulty even in the insertion of the laryngoscope. So in this case, really the best approach for this baby, two things. One, you can see it in the chat. Somebody wrote oral airway. Yes, you can apply oral way and try post pressure ventilation with face and mask, but will be really, you need to be very careful because you may have problem with the seal, mask seal. So the next step or the appropriate step in this case is using supraglottic devices, which is like a LMA. Another case, called early morning before the end of your shift to a delivery room, a mother who's totally unbooked and fully dilated. And on your arrival, the baby was out. And this is the baby. And it's not really unusual to have such a baby in people who work in the NICU or in the delivery hospitals. So this is really a nightmare of every staff, clinician working in a delivery hospital. So as you can see, a case with severe cystic hygroma. So whatever expert, this will be a very challenging, and this is the nightmare, and really, this is the challenging situation if has been faced by any one attending delivery. You need really to have a plan. So this is a case where a difficult airway is really expected. So the effective post-pressure ventilation and endotracheal intubation is or are a fundamental skill for any neonatologist and pediatrician, and they should be really competent to perform this two procedure. Neonatal intubation is the most common and the most dangerous procedure in neonatal medicine. Why? Because it carries a lot of complication such as esophageal intubation, perforation, air leaks, it happened. Subglottic stenosis, one of the complications of endotracheal intubation. And even at the level of tracheal bronchial area, the stenosis may happen. And the more severe complication, or really life-threatening or devastating, what we call it, complication is tracheal perforation. And if it's happening in a small baby, it is really lethal. And most of baby, they die if they have a tracheal perforation. And we face one case of this after trial of intubation, perforation happened, and it was a preterm, and he couldn't make it. So it's really very, very dangerous procedure. And it's been reported. There was an adverse event, bradycardia, desaturation, and it has been reported in literature up to 40% adverse effect, and severe oxygen desats in 50% of intubation of preterm babies. And maybe this is underestimated because majority of intubation procedure in the NICU is not recorded, and the procedure or the complication even not recorded. And I'm pretty sure most of NICU, they don't report side effect or adverse effect from the intubation. And with the every time you intubate, try to intubate, more side effect or adverse effect happen. So, and you can see it's increased from the first attempt of intubation, the adverse effect 25 to double in the second attempt, and increase up to more than 80s if the intubation more than 4, 5, and 6 times. So every time you try to intubate, more adverse event happen during the intubation. So we said difficult airway. So what we mean by difficult airway? How do we define a difficult airway? It can be defined by or as any situation in which physician experience difficulties in any of the following: either face mask ventilation, like a case of laryngomalacia, severe micrognathia, or insertion of the laryngoscope. You could not insert the laryngoscope to see the view, or you can see the view, but you cannot put the endotracheal tube, say intubation. So any difficulty in ventilation through bag and mask face mask ventilation, or laryngoscopic insertion, or intubation is a difficult airway. Adults and pediatric ICU, they have more work in this subject, and a lot of guidelines and a lot of paper in that regard. And they define it as one who's requiring at least 3 or more laryngoscopic attempt by experienced provider to say this is a difficult airway. How common? Adult, 11% in adult ICU, while pediatric ICU is less, 9%. Do you think the neonatal incidence is high or low? Unfortunately, the incidence is not known because, as I said previously, nobody reporting such events. But there is, in 2019, they have a survey from 10 academic NICU. Out of 209 tracheal intubation, 200, almost 280, it was a difficult. So 14%, and that is more than adult and pediatric ICU. And maybe if we really, every unit try to report the difficult airway or during a delivery room or their NICU, maybe the incidence is higher. Another data, like recent data, 2023, and this has been a multi-phased quality improving project in a local NICU in UK, and they collect data over 14 months period and 33 intubation. They found almost 82% of that intubation was performed as an emergency, and 90% of the initial attempt happened by the junior by the fellows, by junior fellows, and 30% first intubation success, but overall success only 50%. And the recorded complication were 33%. So it's really, really high. So why we have a difficult neonatal airway? And if we compare it with pediatric airway, you know, there is really a difference between pediatric and neonate. First of all, neonatal airway is usually, difficult airway usually happen at birth. Not like a pediatric where the baby they come to a PICU at the age of 12 months already diagnosed. But in our population, these presentation happened immediately after delivery. And in our culture, most of the things really there is no appropriate antenatal diagnosis. Also, in neonate, it is rapidly fatal. So if you could not ventilate the baby in the delivery room or secure an airway, the baby will die. And I'm sure most of you, they have at least one incidence of a baby who died in the delivery room because you could not ventilate and you could not intubate that baby. We have a specific group, which is prematurity, baby who require recurrent intubation, prolonged intubation due to chronic lung disease, and babies who's born with congenital malformation. So that's why neonatal difficult airway is unique. Also anatomically in pediatric or neonate, their tongue is large in proportion to the size of the mouth. Their larynx is small. The epiglottis is really floppy and larger compared to adults. And also the larynx is more anteriorly and superiorly. They have very narrow area at the cricoid, and also the trachea is very narrow and less rigid compared to adult and pediatric. So anatomically, the neonate is really different than pediatric and adult. Also, our management in cases of neonate with difficult airway. Most of the time, as I show you the two scenarios, the first responder, usually the junior or the fellows is on call, because this happened really in an emergency. And most of these emergency neonatal difficult airway, the first responder is the junior, who really sometimes have a lack of adequate exposure to such situation or training of how to manage a difficult airway. Equipment which deal with this situation is lacking. Most of the time you go like a case I show you, baby in the ER, baby born, you don't have the equipment there. You did not have like allocated difficult airway trolley, for example. You didn't have a laryngeal mask airway if the like the second case or the first case. So most equipment needed in this situation is really lacking. And lastly, practical guidelines for neonate to manage a difficult airway in case of emergency is really lacking. And now there is some guidelines has been approached and published. Okay, so this is when we define difficult airway. There's differences between two issues: difficult airway versus critical airway. The difficult airway where difficulty in maintaining an airway, positioning may be needing, or there is a difficulty in positive pressure ventilation, or difficulty in inserting laryngoscope, or difficulty in intubation. So it is possible, but there's a difficult. That's where an professional experienced physician in the airway management can manage these cases. They can intubate, they can use airway adjuvant, they can use, pharyngoscope. So difficulties can be passed by having professional experience in the airway management, either experienced neonatologist or experienced ENT, pediatric anesthesia, or a team. While critical airway is really, this is the nightmare of every neonatology. Why? Because you will not bag and mask ventilate these babies. It's really impossible. You cannot, or it's impossible to visualization of the vocal cord or the airway. And you cannot intubate even with the X-tips. So those babies usually, they may end it by fiberoptic intubation in cases of severe subglottic congenital stenosis, or even surgical error. Sometimes even these may not help. So this causes of difficult airway, as we said previously, neonate per se. So maybe we consider all our neonatal patient as a difficult airway, but they have a normal airway. But why predicted difficulties? Because those babies, they have large occiput affecting the position of the baby. So automatically, because the large occiput, the head will be flexed. They have also large tongue and small mouth, which making sometimes really the laryngoscope is difficult. And as we said previously, they have high anterior larynx and very floppy epiglottis. So they have a normal airway, but there is some difficulties maybe seen or during the maintaining airway for this baby through ambu-bagging or through the intubation. Anesthesia has been working pretty good in form of difficulties or difficult airway. and they have classification, they called Cox classification for laryngeal view for all their patient before they go to OR. So they come and assist the patient to see if this intubation will be difficult and what procedure they need to do, if they need to do awake intubation or they need to do an adjuvant for the airway. So they grade the airway view from easy to difficult based on how they can see or visualize the glottis, the posterior glottis. And from grade 1, where they can see everything clearly, to difficult grade 4, where you cannot really see anything. Okay, so this is really unfortunate. We could not apply to our babies. Our babies usually, apart from normal airway, we are having a group of patients where you may anticipate difficult intubation or difficult airway, like babies with chromosomal malformation, congenital anomalies, Down syndrome. It's sometimes really they have difficult intubation. Babies with golden hair syndrome, cleft lip and palate, and really you will have a difficulties. Babies with congenital malformation of the mouth and gum, hemangioma of the tongue. Sometimes we face a case like this, and babies with pear open sequences. So this is known to have abnormal airway, or they have difficulties in maintaining their airway. Other babies, as I said, like congenital lymphangioma, congenital hemangiomas. All these babies may present it at the time of the delivery, and you will really think this baby need an expert people and plan in handling the airway of those babies. So if just a baby need really and maintaining or maintain patency of the airway, you need to have your team and you need to have a plan for these babies even before delivery. There is an entity which came to attention in the recent year, which is, they call it congenital high airway obstruction syndrome. And it's a congenital anomalies of the airway ranging from the laryngeal web to stenosis to complete laryngeal atresia and even tracheal atresia. And these cases, very difficult sometimes to diagnose antenatally, and really it's a very difficult to handle even sometimes. So usually in handling or managing or dealing with babies with difficult airway, neonatologists in ICU should be equipped with an difficult airway equipment, and this equipment should be ready, available, and all the members team, like in ICU nurses, physician, should be familiar with its use. What is these devices or the equipment? We know the equipment. You need to have different size endotracheal blade of usually sometimes you need to have a broad blade, laryngeal mask airway, oral airway, megal forceps if you need to do an intubation in such cases, and this is like equipment should be ready and available in each delivery room and in ICU. And it's better to organize these equipment to make it easy for the staff to use it. For example, you can make a drawer in your ICU, or sometimes like quick equipment and label it as airway supplies. Need like include of that the laryngeal mask airway, oral airway, nasal airway, oral airway, Even sometimes you need bougie. These also an important, and this equipment actually it's available in each NICU, and sometimes you can have it in the OR, but you should make sure this equipment is available in your in ICU and in your delivery room, and should be easy to be accessible by the staff in ICU, fellows, nurses, RT, and just make sure like you check your equipment, resuscitation equipment every day. Check this equipment, please, every day, because the time you need it, you will not find it unless you keep it in mind and check this drawer for the cases of difficult airway. So the basic things, face mask, oral airway, endotracheal tube, and the advanced one, which is really could be available in much of the hospital, the laryngeal mask airway, the different sizes bougie, and also the glidoscope and videolaryngoscope. Some centers they have it. They have it in their OR, I mean. They have it in their ENT department. And it's better to have one in your in ICU. If you look to your pediatric ICU, you may have one. So look if these airway adjuvant is available. Try to train your people about its use. Laryngeal mask airway is very common, and it has been used for a long time for neonatal difficult airway. But now it becomes as a standard from the first attempt of intubation, and is not for only difficult airway. And maybe you are aware about study, even you can use giving surfactant through the laryngeal mask airway. So it is more available now in the NICUs, and it has been used for other indications. And some type of laryngeal mask airway, you can intubate through that. So you apply the laryngeal mask airway, you can light the endotracheal tube, and you can insert that. So look for what type or what type of laryngeal airway is available: Ultimate, Pro, Supreme, and there is a lot of names which is available. You can use it. Videolaryngoscope is really new era in management, and there is a different type and brand of videolaryngoscope. It is useful. Yes, actually, it has been shown in several studies. It is useful, and let's see, show you some videos about how it can be used. So it will be really direct of the airway. So like this, you can see, and not only you, everybody can see. This is the esophagus, and this is the airway. So it has been shown it is really successful of difficulty airway, but it really needs a training. See, very easily showing and introduce an intubated baby, and sometimes even replace the intubated tube too. It's effective. The laryngoscope, videolaryngoscope is really effective. Yes, it has been shown among training pediatric residency program. The videolaryngoscope has been associated with higher first attempt intubation success when it's compared to direct laryngoscope. So we are in the era of everything is visualized, and I think it's really coming. And most of units now, they are the ENT actually, and the anesthesia in the OR, they have videolaryngoscope. So I think it may come to the neonate. You can have it and teach your fellows, your resident, how to use it. It's really simple. But as any technology, you may need, a funding issue is important for such. This is a Cochrane review, and has been shown. Laryngoscopy has shown to increase the success rate of intubation at the first attempt, with number needed to benefit is 5. When you're intubating a baby, especially for elective intubation, it's important to pre-medicate. Don't intubate a fighting baby, because that will increase your failure rate if you try to intubate a vigorous baby. So pre-medication has been really recommended for non-emergency intubation for babies, and the recommended to use recommended medication to be used is atropine, fentanyl, and succinylcholine. And it has been really from evidence-based guidelines for sedation for baby who are going under elective intubation, and that will increase your chance of successful intubation for such baby and prevent a complication. So let's go for the most second part, which is how to approach a difficult airway in neonate. First cases where you anticipated difficult airway, where a center where they have perinatal scans, they told you, or we have like these perinatal combined meeting where they discuss cases which has been diagnosed antenatally with several diseases. One of them is the cases like this, which diagnose antenatally to have severe micrognathia, or these cases where Asher colon was expected antenatal through the 4D ultrasound. So, or this case, like cystic hygroma, diagnosed antenatally with fetal MRI, and it showed the airway is really compromised. So, before delivery, you have an anticipated patient with difficult airway. So what we need to do? It's really important for these cases to have a plan with the obstetrician, neonatology, call a team, the airway team, like your pediatric anesthesia and pediatric ENT, okay? And plan ahead when to deliver this baby. Don't deliver them in the weekend, or don't deliver them in the middle of the night. So it should be arranged a specific time for delivery and place of the delivery. Don't deliver those babies in a level 2 in ICU, where there is really no equipment at all to manage such babies, because if those babies will deliver in tertiary, like in secondary level, or they will not make it. Try to plan your team, personnel, ENT, pediatric anesthesia, and sometimes you need to plan with the OB-GYN, like doing an exit procedure. Prepare the parents also in these cases, because even whatever you do, some cases like this they will not make it. And prepare your needed equipment. Those baby, if they diagnose antenatally, everything should be ready around. Epidural laryngoscope, fiber optic, even surgical airway should be ready in case of difficulty in maintaining the airway after delivery. So the second scenario, a baby born, nothing antenatally, but for example, it's a preterm, or you have unanticipated difficulties. So what do you do? Management usually depends on the first responder skills. So if you get to attend the delivery, there is no antenatal risk, but you have a difficulty You saw a baby, for example, with micrognathia, or you could have a baby with a mass mouth coming out. So what you need to do, try to get help as soon as possible. A person who's a skill in airway management, having clearly delineated approach helps. And remember, human factor is really, really important. People is panicking if you see a case of difficult airway. And equipment training is really vital, as we discussed previously. But remember, sometimes some neonates are designated to not to survive. So we have two things here. You have a baby who delivered, you have a difficult airway, but you can ventilate the baby. You do bag and mask ventilation, there is a chest rise, heart rate is rising, but you try to intubate, you could not intubate. This is a one scenario. The second scenario, you cannot ventilate the baby. So bag and mask ventilation did not deliver effective chest rise. And you tried to intubate and you fail. So this is a scenario where you cannot ventilate and you cannot intubate. So you need to differentiate if you have a baby in the delivery, which category this baby. Can you ventilate this baby? But cannot intubate, or you cannot do both, ventilation or intubation in this case. So we failed intubation in the first time. Most of the time is related to human factor. People is getting panicking. So I cannot really intubate, so it's just like, wow, I could not see the view. So they get really very panicking. So in these cases, please, you need to call for help early. Identify a team leader. I'm sure every unit they have a staff or a fellow who's an excellent, or we say the best managing in the airway, best, the one who intubate within seconds. So try to identify that team and to be a leader or the trial of intubation of such cases. And again, ABC is really important. Assign rule for airway breathing, circulation in order. And remember, you need to communicate effectively and anticipate and plan what to do for these cases. So I failed the first intubation. I tried the first time what I should do. If you failed intubation first time, don't panic. Number one, go back, ventilate and oxygenate with bag and mask, especially in the first case. You can ventilate with the bag and mask, but you want to intubate, you fail, stop, bag and mask, oxygenate. Make sure the chest is moving. You may insert nasogastric tube if you give positive pressure ventilation for a period of time. So sometimes prolonged intubation can cause, stomach to be dilated, and that will compress on the chest, and you need to compromise the stomachs. So sometimes inserting NGT early is helpful, and use the oral airway. Use a Goodell in case of you fail the first intubation. And if you have an experienced person, or you are an expert, because every one of us, they failed first time intubation at any case. Whatever you are expert, you will have a case where you could not intubate from the first time. So if you are expert, you can give your chance, or you can give yourself a second attempt, and it may go well. Why usually we failed the first intubation? Causes. Number one, you never visualize, or you thought, oh, maybe I visualized the cord, the glottis, and this is the view. Actually, you put the endoscope and you didn't see anything. You could not see the glottis, and you thought, oh, maybe that's I will go blindly. So if you never visualized the glottis, this is a failure. So what you will do is very simple. If secretion, you could not visualize because of secretion, you need to suction. If you could not visualize the glottis because the tongue is obscured, the vision, you need to swipe the tongue and maybe use a broad blade laryngoscope. If the baby sometime have an anterior larynx, which really may by hyperextension. So what you need to do, simply reposition, and sometimes cricoid pressure it's help. And really simple techniques, it works, and it may help in such cases. So this is really a simple picture, and they didn't do anything except cricoid pressure. See, you could not visualize the glottis in the picture A, while just applying pressure, cricoid pressure, and you can see the vocal cord very clearly. You can visualize the view very nice, and you can insert the endotracheal tube. The second thing, this is just a simple video telling you how simple jaw thrust sometimes it helps. See, the view is not clear when they apply jaw thrust only. The view very clearly now, and you can insert. So please, first, make sure you visualize the glottis, you visualize the cord, so easy to insert the the endotracheal tube. So let's say that's a scenario, another scenario. It's a first attempt failed. You visualize the glottis, it's clear, but I cannot insert the endotracheal tube. It's not advanced. So what you will do? You may try smaller tube. If you use 3.5, use 3. If you are using 3, use 2.5. So try smaller tube, or sometimes you may need, you will need to think maybe there is something really anatomical problem. So if you visualize the cord and you cannot insert the endotracheal tube, even the smaller tube, you need to think of anatomical problem. Okay? Even sometimes you put the tube in, but there is no air entry. And you're sure, I saw the cord and it's in, I visualize the glottis, it's in, but there is no CO2 detector change, and there is no air entry. Two things, either the ET tube blocked by secretion, big secretion, thick secretion, okay? Or there is anatomical malformation, and in these cases, you need to call a senior help ENT as soon as possible. So another attempt is tried. Can ventilate with the bag and mask ventilation. Basic is the same. So you did another attempt, you will continue bag and mask as you have a good chest rise, saturation is acceptable. So call your senior, continue bag and mask ventilation till the help is arrived. This is a scenario where sometimes you cannot intubate, but you can bag and mask ventilate through the, for example, oral or laryngeal mask airway. And these cases, what you can do, don't try to intubate, try, please. What you can use, iGel, which is laryngeal mask airway, or sometimes galeidoscope will help because they have severe airway problem and severe micrognathia, and sometimes not really even in laryngoscope. You can wait, but you can't intubate. Failed of intubation due to another problem, which is the subglottic or glottic obstruction. As I said, secretion need to be really ruled out. Number one, try to good good suctioning. Avoid trial of attempt free intubation. Consider anatomical anomalies. Give continue positive pressure ventilation. Call for help, ENT, pediatric anesthesia, whatever is available. And you may try laryngeal mask airway in these cases till the help is coming. So coming to the scenario where you cannot ventilate and you cannot intubate. So trying to bag and mask ventilation, baby is blue, saturation is high, low. Try to intubate, you cannot intubate. So what to do in these cases? First of all, make sure it's not obstruction with secretion. Try to avoid, if you could not really intubate, in these cases, you need to think very hardly. This is an anatomical malformation or anatomical anomalies causing an obstruction. Try to call and help pediatric anesthesia to perform fibro-optic intubation. And in these cases where you cannot ventilate from the beginning and you cannot intubate, those baby may need urgent surgical airway. So you cannot be able to ventilate those baby with all trial of the adjuvant airway. Those baby, they need a surgical airway. And this is a case where congenital malformation, where you cannot ventilate the baby and you cannot see those baby. You can see clearly there is complete atresia of the airway. Okay? So whatever you cases, you cannot ventilate. Okay? So this is a scenario where wherever you give bag and mask and intubate, you cannot see these cases. You cannot be able to ventilate such cases. This is usually really a life-threatening situation. If you diagnose them antenatal, as we said, you called help immediately. And if really you have a baby in the delivery room, you ambu bag him, bag mask ventilation, there is no chest rise, you call ENT, you can try to intubate with the most senior, you called immediately for help. And these cases really, they may not really make it. I recently, a few months back, I have a similar case in the delivery room. They called me, they could not ambu bag this baby. I tried to intubate, the tube is not passing. So we called the ENT in the delivery room. They did a surgical airway. Anyway, so meanwhile, we optimize phasal mask ventilation, try to make your positions, try to two-person technique, jaw thrust, oral airway, decompress the stomach. So try to optimize the face mask position, because possibility of obstruction other than the anatomical obstruction is still there. Consider using laryngeal mask airway. Trial of intubate. If you tried once and you could not make it, maybe you call your senior neonatologist to help you and try to intubate, with most senior, maximum 2 trial by a senior neonatologist, till the ENT or the pediatric anesthesia is available or is around. Remember, in these cases, you need to have a team approach. Immediately, if you face a such case, inform your consultant or the most senior staff in the NICU. Prepare your team, call your team to be around, doctor, nurses, RT, assign the rules for each one. And really in the magic point for resuscitation, for airway management difficulties is preparation. So if you can ventilate but cannot intubate, each intubation attempt should be limited 30 seconds, and that because why 30 seconds? To minimize the risk of hypoxia. And each step should have each person or skills maximum 2 attempts, but total you should not have more than 4 attempts of intubation, and you need to ventilate in between. Why you should not have more attempts? Because in these cases you can ventilate by bag and mask, but you cannot insert the endotracheal tube. If with the trial of intubation, especially trauma may happen, trauma to the airway. Trauma to the airway can lead to edema and obstruction. And you will change your scenario from a case where you can ventilate to a case you cannot intubate, and even you cannot intubate because you ventilate, because you introduce trauma to the airway, and that will obstruct your airway. So you change your scenario from patent airway from with ambu-bag to complete edema and obstruction to the airway. Okay. So if intubation is unsuccessful, what you should consider, as I said, all these time should be considered using laryngeal mask airway, using laryngoscope, video laryngoscope, which is the gold standard for these cases. And sometimes you may use other devices for intubation. Sorry. So consideration for these cases where you need to may use the indirect video laryngoscope, use bougie, stylet, rescue technique, and lastly, the percutaneous tracheal puncture using 16 gauge cannula. And really, this is, it's an emergency, but it's not has been really recommended so far for such cases, especially if you don't have an experience by doing the percutaneous tracheal puncture. ENT is really fundamental to considered emergency treatment for such cases. This is how to do percutaneous tracheostomy, tracheal puncture in unit. But again, I really not recommend it because it's not universally considered acceptable. But there is some document has been support its use. If you have an what we call it training in such, and to my knowledge, none have really us have a training in such emergency. But some some ANT may do it in the hospital. There is a lot of guidelines, and there is protocol has been initiated about management of difficult airway. So you need to have a plan, and each unit, each in ICU, each hospital should have a plan what to do in case you failed intubation. So if you failed intubation, for example, this is one of the guidelines. I just literally take it from, I think, from UK. If you failed intubation, but you can ventilate, what to do, call senior, 2-person to do jaw thrust, oral airway, suction, and try different laryngoscopic plan. They have really plan A, plan B, plan C, and plan D. So, for example, if you failed intubation and you cannot ventilate, oxygenation, and called for crash team, anesthesia, ENT, and a senior neonatology, and considered surgical Airway, tracheostomy in cases of worsening hypoxia and bradycardia. And sometimes you need to call them earlier before you reach to that extent. So in conclusion, difficult ventilation and tracheal intubation in neonate is higher than pediatric and adult patient in ICUs. We're intubating neonate carefully. You need to consider the following. Number one, who performed the intubation? What's medication used, especially for the elective? And what device should be used for those babies? And proper position is crucial for successful neonatal intubation. Call for help early if unable to ventilate or intubate. Continue to provide oxygen with bag valve mask ventilation. Additional work really is needed to make neonatal tracheal intubation safer. Teamwork, difficult airway protocol, equipment needed, and the staff should be aware about where is it and the function of each equipment, and training and simulation really needed in these cases. The British Association Perinatology has been published guidelines, and really maybe it's a 15 pages recommendation, and they really recommended every neonatal center should have an agreed approach to difficult airway management, put a plan, who to call, where to call, just to make it an easy for the staff who face such cases or such situations. Readily available difficult airway equipment and familiarity with its use, and regular related training to the staff, nurses, RT for these cases. And so what if I cannot get these 82 in this airway? Please, the message, stop trying. If you try to intubate and you fail, stop trying. Why? Because most important thing is ventilating that baby, not the insertion of the endotracheal tube. And remember, some cases, whatever you did, it may not be helpful. This is a case in New England Journal of Medicine, 32 weeks baby. They tried to intubate in the delivery room, unsuccessfully. They tried, they called the ENT, they tried to insert airway, surgical airway. Baby died at 4 hours. And when they did, you can see the contrast study, there is a complete tracheal atresia. And there is, just the bronchus, main right and left bronchus, attached to the esophagus. So some cases or some babies, their destiny to die. So whatever you did, you may not really help. Thank you very much. And I'm really happy to answer any question. Thank you.
Okay, thank you, Dr. Jubara, for your time, effort, and for sharing your knowledge with us. I hope you all enjoyed with the session. So if you have any question, please feel free to write them in the chat.
Dr. Wajdan, some questions I can see from the the question answer. Can you just see it?
Yeah, Q&A, Doctora. There's 4 questions.
Yeah, from Dr. Ali. First, he said, if I'm working in rural area, delivery with baby with cystic hygroma, what can I do? This is critical situation. I don't have facilities or subspecialty.
Okay, excellent. This is not unusual, and from our life-saving calls, we receive such cases. Really in a rural area where a pediatrician who sometimes they don't experience intubation within 2 years. So if your baby, you can ventilate and you try intubation once, intubate. Don't intubate. Continue bag and mask ventilation. call for life-saving. We received babies. We send babies to facilities with bag and mask ventilation only, as you have adequate bag and mask and ventilation. Even in like a rural area, they have an oral airway. So you can use oral airway. If you have laryngeal mask airway, go ahead and call for help. But it's the best scenario in these cases. Those baby with cystic hygroma or airway, you know, hemangiomas or sarcoma, whatever obstructing the airway, most of them diagnosed antenatally. So it's better if the mother came in a rural area, not in active delivery, send the mother, call for life-saving, and send the mother to deliver in that center. But if you face the baby and deliver in your institute, start ABCs is the same. And I can show a picture, babies with huge cystic hygroma, they are breathing in their own. So if they are breathing in their own, don't touch them. Don't sedate them, and don't try to intubate. If they are maintaining their saturation, maybe you can just put an oral airway, keep them at the site, and transfer them. Some baby, they deliver in a rural area where you don't have any facility to do anything, and they need that airway. You can try, you know, to give an intubation if you are skilled, if you have whatever, use your available resources. Whatever you have, you can use it. But sometimes, as I show you in the picture, sometimes really some baby they don't make it, especially the baby with high obstruction. Okay, the second question, how can
second question, how can improve our antenatal diagnosis, especially in peripheral hospital, to give time to us transfer the baby to a tertiary center?
Okay, okay, this is really a good question. Perinatal or antenatal diagnosis. It's need really a good skills, you know, personal. Sometimes ultrasound can be easy and simple technique. If they have a doubt, the healthcare system in Saudi Arabia, even in the peripheral hospital, they have an access. Okay, they can send the picture if they are really doubting of something. And transferring picture and they doubt, you know, especially if they have a doubt of MS or something critical, or sometimes even the complex congenital heart disease, if they diagnose antenatally, communication with other hospital, referring hospital will be very helpful in such cases. If perinatology or obstetric in peripheral hospital, they have a doubt of a case, they can send the picture to start with to a referral hospital through the life-saving system, and they can see the picture in the tertiary perinatal services, and from that they go for either do more picture or maybe transfer the mother for more images. Sometimes they need MRI, sometimes they need an exit procedure, which cannot be done in the peripheral hospital. Okay.
Third question, a baby with bilirubin syndrome. It was difficult intubation leading to prolonged hypoxia due to failure to intubate it after 3 trials. How many attempts allowed? And what about medical legal concern for failure of intubation?
Okay, how many attempts allowed? As I said previously, it has been recommended no more than 2 attempts per a senior. So if you tried intubating a patient, can we call for another one to try, another 2, maximum 4 trial, okay, documented, please, with the timing. So sometimes even you try twice and you said, okay, really it's very difficult, I cannot. Pure open sequence, as I said, sometimes just you need laryngeal mask airway. If you try for open sequence, if I try intubate once, maybe I will stop, I put oral airway or LMA and I call for the ENT. But what has been documented, maximum 4 times, and then give bag and mask ventilation. And I said clearly at the end, the aim is not inserting the endotracheal tube. The aim is ventilating the baby. So if you can ventilate the baby with the oral airway, that's good. So ventilate him till refer him for, or call for a senior or something. Medical legal, it's really difficult question here because important, it's not only the tube or what to do. It's known complication, and it's known difficulties. Cases of perioperative failure of intubation is there, but you need really to document. Number one, is intubation justifiable? Do you really need intubating that baby? Can you do an alternative way where you can give airway through another things? For example, as I said, laryngeal mask airway, oral airway, and we have a lot of cases. They are in the oral airway for 5 days till the ENT, decided to do some sort of trick, So yes, important for you for a peripheral hospital where you cannot have the facility sometimes. Really think carefully. This baby need the tube, or I can manage without tube. Especially the perioperative is a case where you can ventilate, but you cannot intubate. So ventilation is possible for these cases through oral airway, laryngeal mask airway, sometimes even nasopharyngeal airway can help in these cases, rather than try of attempting inserting the tube and causing more damage, more airway edema, and difficulties in inserting the tube, and change the scenario from you were able, there is only anatomical in the problem in the inserting of the laryngoscope and because of the small mandible, to complete obstruction where even you cannot ventilate now with alternative devices.
Okay, we have 2 more questions. What to do if ENT senior refuse to do emergency tracheostomy?
Okay, this is an interesting question. So why, can I ask why the ENT refused to do emergency tracheostomy? What the rationale why he said I will not do emergency tracheostomy? Because I cannot see the question.
Yeah, it's no answer. Dr. Isa?
Yeah, because that's why we said every hospital, every NICU should have a delegated team, which is an airway, including the ENT, so they know what we need from them. We called sometime. I told you, like recently, a few months ago, I have a case in the delivery room. They called me. They could not intubate the baby. They could not ventilate. I tried myself. I called the ENT. They came. First thing he said, I can intubate. I said, go ahead and intubate. I tried already twice. Then he felt, he did trach, emergency trach, and the tube, even with the trach, it was not going on. So he cannot pass the tube through the tracheostomy, and that case were tracheal agenesis. So the ENT team, usually you should have a good communication with them. Rationale, why you call them? Do you call them, do you need the fibro optic scope? Do you need an intubation to video laryngoscope? Or do you need an emergency trach? So communication with the ENT and pediatric anesthesia really, really important between the neonatology, pediatrician dealing with these cases, and have a guideline. Just write a guidelines. Sit together, your team, with your ENT, pediatric anesthesia, and just you can write an algorithm what to do in cases of difficult airway. Sometimes they come and they do, fiber optic for you. They don't do trach. And sometimes they come, they said, okay, I will go and do trach. So if they refuse, he need to write it. Say what is his rationale, why he refused.
He said fiber optic not available. ENT want general anesthesia to intubate.
So maybe he's not a pediatric ENT. That's why they want the anesthesia to intubate. If he's in a peripheral hospital. So again, the expert people in your center or your hospital, you know who they are. For example, if you don't have a pediatric ENT, but you have anesthesia who's really more capable of intubation, and some anesthesia they do trach, emergency trach, or even needle sometimes. So talk to your team and see. Emergency tracheostomy, trach is an emergency. We're talking about emergency. You don't need anesthesia. You don't need, under GA, it's an emergency. Either you create an airway, you secure airway, or the baby will die. So this is no discussion. But maybe in a case of baby who's intubated for 4 days, 3 days, had a bilateral corneal atresia, or had a peer open, and they want an elective tracheostomy, this is a different story. But our discussion today about the emergency tracheostomy, where it's a life-saving, either this baby will survive or will die, especially if it's not a congenital lower airway obstruction. So it's the tracheostomy is really an emergency. You didn't need really a discussion about it. Either yes, come in and do it, or the baby will die.
Okay, last question. In case of diaphragmatic hernia with difficulty ETT, how to use BBV?
Okay, excellent question. Again, baby with difficult airway, diaphragmatic hernia. Now, you cannot intubate the baby. In these cases, use laryngeal mask airway. Use a stylet sometimes to help you, because if congenital diaphragmatic hernia, again, the problem, they shouldn't have a problem with the airway unless it's a part of syndrome. A baby had some sort of syndromes where both he had diaphragmatic hernia and airway malformation. So you can use, if I try to intubate first time, and this baby is not, and remember, diaphragmatic hernia, it's you need to intubate immediately. So sometimes try the first intubation with the most senior case, especially diaphragmatic hernia. Most of the cases, antenatally. Most of the cases, I can say. So the most senior, a team should attend the delivery. Try to if you okay, insert laryngeal mask airway and bag through the laryngeal mask airway. Okay, tell the senior come and help. Okay, if you have the laryngeal mask airway with the one you can intubate through that, you can use to intubate. You can intubate through the laryngeal mask airway. Okay. Remember to insert nasogastric tube immediately for these cases, because with ambu-bagging, in this case of diaphragmatic hernia, you just inflate the bowel in the chest, and you may not have adequate, ventilation of the not affected lung. To the what we said, we cannot say normal lung, but maybe one of the adequate ventilated lung. So my advice, try to intubate once, call the senior, insert laryngeal mask airway. If you can intubate, if your laryngeal mask airway, you can intubate through that, you can do it. And if you failed, continue with the laryngeal mask airway ventilation. I kept the baby 3 days on the laryngeal mask airway with mechanical ventilation. Okay. Any more questions?
No more. Thank you, Dr. Jubara.
Thank you, Dr. Wajdan. Thank you for the audience for staying with us tonight. And thank you for the organizer. And have a good night.
شكرا جزيلا دكتورة. Thank you very much.
شكرا لكم.